Good afternoon, ladies and gentlemen, or good morning or good night, depending on from where you are joining us today. Dear colleagues, it is my great pleasure to welcome you to this traditional Thursday Satellite Symposium hosted by Fujifilm on occasion of the 24th Düsseldorf International Endoskopie-Symposium. Unfortunately, due to the still ongoing pandemic and related restrictions, this satellite symposium, as well as the main congress, will be held in a total virtually format again. As you know, however, we are confident that all participants and ourselves can look forward to an exciting program, 3 days of full of endoscopy. So first of all, it's also my great pleasure to welcome my co-chair of this satellite symposium, Professor Klaus Mergener from Seattle, United States. And Klaus, I would like to express my personal heartfelt gratitude that you personally came over to good old Germany and to support us on site here in Düsseldorf. Of course, Professor Mergener does not need any further introduction, as he is also the current past president of the American Society for Gastrointestinal Endoscopy. Furthermore, I would like to thank Fujifilm again for hosting this satellite symposium and their ongoing support also during these difficult times and their close collaboration. We all can be very honored to have an outstanding international faculty for this satellite symposium, renowned international experts. This satellite symposium is dedicated to recent advancements in therapeutic and diagnostic endoscopy. First part will be dedicated to the upper, second to the lower GI tract, and each part will be followed by a panel discussion. And to our participants, I recently heard that we have now more than 500 participants already. So please stay tuned and help us to be as interactive as possible. Send in your comments and questions via the chat function, and we will deal with this in the discussion part. But now it's time to introduce our first speaker. We are very honored to have him on board, Professor Pratik Sharma from Kansas City, United States. He's probably one of the world's most renowned experts, pioneers, and opinion leaders in the field of Barrett's esophagus. And we are so honored to have him here and listen to his lecture on the impact of advanced upper GI imaging on clinical practice and patients' outcome. Pratik, the floor is yours.
Hello, everyone. This is Pratik Sharma from Kansas City, and I'm going to be discussing the impact of advanced imaging on upper GI tract and how does it impact clinical practice and patient outcomes. And it's my pleasure to participate online. However, I do wish I was in Düsseldorf with all the faculty, but more importantly, hopefully very soon in person with all the participants. So what I thought is I would just split this diagnostic part up into the major important GI diagnosis that we deal with on a regular basis: gastroesophageal reflux disease, squamous cell cancer of the esophagus, Barrett's esophagus, esophageal adenocarcinoma, and then also very important for a large portion of the world, which is gastric intestinal metaplasia and gastric cancer. So let's just discuss this one at a time and see how can we improve the diagnostic criteria for these different conditions. This is, of course, severe reflux esophagitis in a patient with chronic reflux symptoms, in which you can see scarring from the disease as well as grade
Yeah, I just recently heard that we have some problems with our with the video that was running. So in the meantime, we can already start the discussion while we fix this problem. So we have nicely seen this image of Barrett's esophagus and the marking of all the areas that are suspicious for dysplasia. So. Pratik, maybe you're also now online. Maybe you can answer now one question. Do you think if we have a look at current endoscopes that are equipped with advanced imaging technology, is there still a role for endoscopy without these kind of image enhancement technologies to detect neoplastic area, or do we all have to switch to these kind of endoscopes?
Hey, Torsten, can you hear me okay?
Yes, very well.
Okay, perfect. Hey, thank you. So my pleasure to see all of you as well. And thank you for that question. Hopefully the audio will work. I mean, the other option obviously is I have the slides I can present from my computer as well if that doesn't work, or do it later. So thanks for the question. I think it's important. And I still do think that the major role is played by white light endoscopy. I think we just need to keep getting better looking at that and finding the lesions. All these advancement techniques do help us. They play a supplementary role, but you do have to learn it in a stepwise manner. So first go with the first white light endoscopy, and then with the image enhanced techniques. So that's how we have approached it. And also amongst the techniques, I'd say that, use one, stick with it, get better, and, try to be as good with that technology as possible. So rather than trying to learn both, dye-based chromoendoscopy, confocal, virtual chromoendoscopy, and all of those, if you have limited time and resources, pick one. Try to use it on a regular basis and, start becoming good at it.
Hey, Pratik, let me quickly add my welcome to the faculty and most importantly to the attendees of the meeting. You can, for those of you back at home watching this, you can already tell why Torsten and Pratik are among the world's best interventional endoscopists. It really has to do with troubleshooting and being able on the spot to improvise. We apologize that we have some technical issues. We're working on them as we speak. In the meantime, Pratik, if I could ask you to maybe also comment in terms of white light endoscopy and diagnosing Barrett's esophagus. You've done the studies and shown us that doing what we do in the colonoscopy world, taking time, spending more minutes looking at Barrett's is beneficial. So this is probably going to come up in your talk, but maybe we can preview the importance of just due diligence and spending time in the esophagus. How much time should I be spending when I see Barrett's to really evaluate the mucosa in detail?
Yeah, good question, Klaus. And just to the AV person who was sending me a message that they are still having some technical difficulties. So if you could just let me into the room again, I'm from my laptop. I can start presenting that. So
Pratik, the advice from the AV team was that we would postpone your lecture to a little bit later, and then we could proceed with the next lecture and then continue yours after that. Is this okay for you?
Yeah, that's absolutely fine, Torsten. Do you want me to present from my computer, or will they be able to play the recording?
We will fix the problem in the meantime, and then we would lead over now to our next speaker. So I was prepared to introduce Ulrike Denzer, but I heard that you started your endoscopy career together with Klaus Mergener, and so you would like to take the chance to introduce himself.
Absolutely, I wouldn't let Torsten do that. It's actually Actually, it's a wonderful opportunity and it's a great pleasure to introduce to our audience Professor Ulrike Denzer, who, as Thorsten was just saying, started her career at Mainz University, went to Hamburg, and is now leading the Endoscopy Center at Marburg University. It's wonderful to see you, Ulrike, and we're looking forward to your talk. Tell us a little bit about advanced therapeutic techniques then in upper GI endoscopy. Welcome.
Dear ladies and gentlemen, dear Chairman, thank you for giving me the opportunity to talk about advances in upper GI therapeutic practice. Please note the following presentation can only be a selection and is subject to personal bias. I will organize my presentation according to the following topics: endoscopic resection mainly, and finally briefly from submucosal endoscopy to Tenga diverticulotomy. Early carcinomas and premalign lesions of the upper GI tract can be resected en bloc or piecemeal. Based on the existing evidence and guidelines, there is consensus on en bloc resection of esophageal squamous cell carcinoma, gastric carcinoma, and SET. For Barrett neoplasms, current data suggest the possibility of both en bloc and piecemeal resection. Duodenal adenomas are mainly resected piecemeal in EMR technique in Western countries due to the high risk of perforation of ESD. Nevertheless, en bloc resection in ESD technique is becoming more widespread in Western countries. As an example, the German ESD registry, including 1,000 procedures at 20 centers, has been published last year. Procedures were undertaken in different locations. Curative resection rate was about 70%, recurrence rate about 2%. Recurrence rate and curative resection rate depended on case numbers and were better in high volume centers with over 15 ESDs per year. However, the study shows that ESD is also becoming more common and widespread in Western countries. Since the method requires a learning curve, there are different approaches to simplify ESD. In conventional ESD, gravity can be used as shown in this example with a resection of a leiomyoma in the esophagus. After circumferential incision, the lesion is dissected from proximal to distal and can then be completely resected distally following the gravity. Here's the final cut. Traction methods provide more space and visibility for dissection as the specimen is tightened. One option is the clip and line method. This case shows an ESD resection of an esophageal squamous cell carcinoma. After circumferential incision and dissection from proximal, here the dissection is a little bit wider, space from proximal, then a clip is anchored with a suture. This tightens the specimen and simplifies the dissection from proximal to distal, especially in case of larger resection areas like this. As you can see here, most of the dissection is already done. And we are working from proximal to distal with a good visualization. And then the final cut is done at the distal part of the incision, and the specimen can be retracted en bloc. For wide field ESD, especially in the esophagus, the tunneling method can be used. With this technique, a tunnel is created from proximal to distal under traction. The sides are then cut. The technique enables also circumferential resections if needed. Further resection methods include the use of a double channel endoscope or the use of an additional working channel. With this method, the specimen can be held with forceps and simultaneously dissected with the ESD knife through the second channel. A new device is the track motion system, a 360-degree free-moving attachment for the double-channel endoscope. Here, instruments can be freely rotated as a second examiner's arm. This could facilitate ESD, especially in the stomach and in the rectum. Whether traction methods save time in ESD has been investigated in comparative studies. Most studies showed a significant advantage in the esophagus and stomach with a shorter procedure time, but without differences concerning complication rate or en bloc resection rate. Since the studies were performed in expert centers, less experienced investigators are likely to benefit more. Injection deals, which allow a longer duration of the submucosal injection, can further facilitate ESD and endoscopic resections. Especially dissection and visibility of blood vessels may be simplified as shown in these gastric ESD cases, one adenocarcinoma and one NET type 3. However, there are no published comparative in vivo studies here yet. The choice of ESD knife depends mostly on education and training. Recently, I had the opportunity to use the new ESD flush knife from Medwork in an ESD of a Barrett's carcinoma. As you can see in the video, especially the injection is easy with little pressure, and the dissection is effective, even in fibrotic areas. I would like to briefly mention endoscopic full thickness resection. Indications in the upper GI tract are suspected GIST lesions of more than 2 centimeters originating from the muscle layer, undiagnosed set in younger patients weighted against long-term follow-up, and non-lifting lesions. We differentiate two techniques, the cut and close and the close and cut technique. The cut and close technique resects SET in the stomach transmurally completely. A perforation is created, which is closed with closure techniques such as clips. Most data on this technique are found in Eastern studies with a fairly high rate of GISTs for the stomach, resulting in more than 80%. Lesion sizes range from 1 to 3 centimeters. Probably the high GIST rate was due to a good pre-selection of patients, and it is not clear whether this data can be transferred to Western countries. A new technique in this field is the ESSD, the endoscopic subserosal dissection, where an ESD of muscle layer is performed with preservation of the subserosal layer and probably minor complications like pneumoperitoneum. This is certainly a highly specialized resection technique whose further development and indication field remains to be seen. The first close and then cut method using the EFTL system allows resection of gastric and duodenal lesions up to 2 centimeters. For the upper GI tract, only case series are available for this method so far. Currently, a prospective trial is investigating EFTL in gastric set up to 2 centimeters with a primary endpoints GIST rate in a Western population and resection rate, and we have to wait for this. The next topic I want to talk about is the endoscopic resection of non-ampullary duodenal lesions. In the Western world, these lesions, mostly adenomas, are usually removed by EMR due to the high perforation rate of ESD in the duodenum. This is done, as in this case of a larger duodenal adenoma, usually using lifting injection and then hot snare resection in piecemeal technique. Different snares are on the market here. I personally prefer the monofilament snare for flat lesions because of the good power transmission and the clean cut edges. Mostly retrospective studies have investigated the outcome of EMR in the duodenum. Here, a recurrence rate of about 10% was shown, but the main complication was the delayed bleeding between 4 and 17% due to the good vascularization of the duodenal wall. One possibility is to coagulate bigger vessels after resection, like in this case, or to apply a gel prophylaxis. But data on this are currently lacking now. Here we see the resection area, and we do coagulation of bigger vessels for bleeding, delayed bleeding prophylaxis. For smaller duodenal lesions, following the data in the colon, there are initial studies on cold snare resection up to 6 mm and currently up to 10 mm without relevant rebleeding. Therefore, this has already been included in an ESGE recommendation concerning duodenal lesions up to 6 mm. Altogether, cold snare resection seems to be a safe alternative for EMR of smaller duodenal adenomas. Regarding the endoscopy, submucosal endoscopy in the third room, the POEM technique is now well established for therapy of achalasia. Here, the randomized study of Werner et al. Proved non-inferiority compared to helamiotomy. Current topics for POEM are optimal cut length in achalasia type 1 and 2 and reflux prevention. Although comparative studies for achalasia type 1 and 2 showed no difference between a shorter and a longer myotomy. In type 2, a tailored myotomy considering the spastic individual segments seems, to my opinion, potentially beneficial. POEM introduced other tunneling techniques in GI endoscopy. One of them is the Senka-POEM method. Finally, I would like to briefly discuss the various flexible Senka myotomies. First, the conventional incision of the Senka bar using a needle knife. After removal of the Senka overtube, in this case, we deepened the incision to the diverticular floor a little bit more using the needle knife so that this space is really flat, but without causing a perforation. And finally, a prophylactic clip closure was done. Another technique is the incision with an endoscopic scissor, the clutch cutter. In this case, from the endoclop north, a double incision is made on the left side and then on the right side using this endoscopic scissor, which works with monopolar current. And the double incision is then followed by a snare removal of the middle part of the Senka bar using a 10 mm snare. After that, the overtube is removed and subsequent clipping takes place. In both cases, the Senka bar is really flat now. The third method is the set POEM technique. This technique is based on a tunnel entrance and then complete myotomy of the Senka bar, as shown in the video in the middle, under the idea of a hypertensive muscle contraction of the upper swallow muscle and subsequent clip closure then of the entrance. Up to now, it's not clear whether method is most effective or which method is most effective. There are now two retrospective studies comparing set POEM, flexible endoscopic septotomy, and rigid septotomy. According to this data, the methods have an equal efficacy with partially a lower complication rate of set POEM. Possibly the set POEM approach is one approach for small spastic Senka diverticular and the incision method useful for deeper Senka diverticular, but here prospective comparative data are needed. So I want to conclude. ESD is gaining acceptance as a resection method in the upper GI tract, also in Western countries. Further development of technique and material may simplify the method. Endoscopic full wall resection of gastric ascity is evolving. Prospective studies are needed to define the clinical importance in Western countries. Cold snare resection in the duodenum will develop similar to cold snare resection in the colon, especially for the reduction of postoperative bleeding. And currently we have several technical options for flexible sengamutomy. Prospective comparative studies are necessary to determine the best method for the individual case. And thank you for your attention.
So thank you, Ulrike, for this comprehensive overview. So a lot of techniques that we can discuss in a joint panel discussion after Pratik Sharma has finished his lecture. So I will directly give back to him to finish his lecture. I think he will share his slides now from his own computer. So yeah, Pratik, please go on.
Okay, can you see me, hear me, and see my slides, Torsten?
Not yet. I can only see myself. Now, but your camera maybe is switched off. I can see your slides. Yeah, now you're there.
Okay, perfect.
Great.
So this is great. I get to give my lecture twice. Never done that before, but this is great. So again, Klaus and Torsten, guten Morgen, and great to see both of you there live. Of course, wish we were all there with you in person. So I'll try to wrap up my lecture on impact on advanced upper imaging on clinical practice and patient outcomes. And what I've broken down this into is the common upper GI diseases that we face, on a global basis, just because the audience for this Düsseldorf symposium is truly global. So starting with gastroesophageal reflux disease, squamous cell cancer, which we sometimes tend to overlook, but is the predominant type of esophageal cancer worldwide. Then, of course, Barrett's esophagus and esophageal adenocarcinoma and gastric metaplasia and gastric cancer. So let's start off with gastroesophageal reflux disease. And this is a patient with grade D erosive esophagitis. And the question Torsten had earlier was, the role of white light imaging, which you can easily see in that situation. But how about for non-erosive reflux disease, which requires pH monitoring, maybe impedance, a trial of PPI? What we have recently done, and this is submitted by the Kansas City Research Group for DDW, is to look at advanced imaging for a diagnosis of non-erosive reflux disease. So we took two sets of patients, NERD, which were defined as no endoscopic evidence on white light endoscopy of erosive esophagitis, and pH monitoring was positive, and we compared it to controls. And we looked at several features on virtual chromoendoscopy, either IPCL tortuosity, the presence of a ridge-villus pattern at the squamocolumnar junction in these patients, and as well as the presence of microerosions. And what we were able to find in this study was that several of these findings of IPCLs, ridged-villus pattern, and microerosions were significantly more common in NERD patients, which is the larger population of the GERD population, as compared to controls. And the most important finding was that of a ridged-villus pit pattern at the junction. This resolved in all NERD patients after PPI therapy and also had a significant correlation with abnormal 24-hour pH monitoring. So our proposal is that this could be a feature of NERD, which we can diagnose even before going to pH monitoring in this situation. Next is, let's look at patients with Barrett's esophagus and esophageal adenocarcinoma. This is, high definition white light endoscopy being performed. And you will see that after cleaning the esophagus, here is the early Barrett's cancer that you're seeing at the 12 o'clock position. This is, of course, something which can be missed if you don't pay attention to it. You're not doing a careful withdrawal in these patients. And these are the types of cancers that you want to diagnose because these are curative cancers. And we just heard about resection or ESD or EMR in patients with Barrett's, and you can only do it if you diagnose them early on and do it. What are some of the image enhancements that we can be used? One is acetic acid chromoendoscopy. And this is a technique which is pioneered by the UK group. And this is looking at high definition white light endoscopy in a patient with Barrett's esophagus. And if you spray acetic acid, after a few minutes of the aceto-whitening reaction, what's left is areas of high-grade dysplasia which stand out, as is shown in the circle here. So this is a simple technique, but again, requires experience, requires usage over and over again for you to become familiar and start utilizing it. Most of us have switched to non-dye spraying chromoendoscopy techniques, such as virtual chromoendoscopy with narrowband imaging or blue light imaging or eye scan. What this does is not only allows you to recognize the visible lesion, which is seen in the 12 o'clock position, but also the flat high-grade dysplasia, which is extending from the 12 o'clock to the 4 o'clock position. This is important because this is the only way you'll be able to do a full on-block resection or get an R0 resection in this situation. So imaged enhanced endoscopy really helps us to do that. How well does this perform? This is the Bing classification, or the Barrett's International Group Classification, in which a group of experts looked at several hundred images of different pit patterns of NBI, and we characterized it into either a regular or an irregular pattern. And at least in expert hands, this seems to work reasonably well in this situation. Similar to that, the BLI group has come up with what's called the Blink classification, and very similar sort of themes that you will see. So for the audience, I think the take-home message is pay attention to the mucosal pits. And that can allow you, for example, this is a regularly arranged and normal pit pattern, which is non-neoplastic. Pay attention to the blood vessels. And if the blood vessels are distorted or loopy or dilated, that's more suggestive of neoplastic Barrett's esophagus. And then also finally pay attention to the color, because abnormal vasculature leads to a brightness in the color with BLI, and that will stand out as a neoplastic lesion. This group showed that the sensitivity of neoplasia detection using this Blink classification was extremely high, and also that for general endoscopists, from pre-training to the post-training, there was a significant increase in their accuracy of being able to diagnose a neoplastic Barrett's esophagus using BLI in this situation. How about squamous cell cancer of the esophagus? And I did mention this, that this is actually a cancer. If you go to Asia, Japan, Africa, Russia, this is the predominant type of cancer. And so also in the US and the West, those patients with risk factors, smokers, alcoholics, history of achalasia, history of head and neck cancer, we should be paying attention to these subtle lesions, which I sometimes think that we may be missing out on. This is taking you from the left. This is white light endoscopy. You can start seeing something abnormal here. On virtual chromoendoscopy, this becomes more pronounced, but the best images that you get is truly with Lugol's chromoendoscopy. So this is still one neoplastic area of the luminal GI tract in which dye-based chromoendoscopy would still be quite helpful over and above virtual chromoendoscopy. When you magnify with virtual chromoendoscopy, either NBI or BLI, what you're looking for are these modifications in the IPCLs. This is the intrapapillary capillary loop, and there's the Inoue classification of characterizing from dysplastic to invasive squamous cell cancer of the esophagus. And you're looking for dilation, weaving, change in the caliber, as well as change in the form of the IPCLs. So let's look at a couple of examples here. On the top is white light imaging. On the bottom is virtual chromoendoscopy, and these are corresponding images. So this is patient A here, and you can see this lesion here, and then you can see the second lesion and the corresponding image on imaged enhanced endoscopy, and you can see how it really makes it stand out. Similar classification here, you go from white light imaging to Lugol's chromoendoscopy, and then you magnify and you start seeing the IPCLs here. And look at this IPCL. One way always to try to learn this is comparing it to the surrounding mucosa. If you pay attention to the surrounding mucosa, you can see these are the pin or the dots of the IPCLs, and compare and contrast it to this area of mucosal cancer of the esophagus, which can be resected for cure. Finally, or looking at gastric intestinal metaplasia and gastric adenocarcinoma, again, a very important health problem globally. Gastric intestinal metaplasia is important because, like Barrett's, this is the precursor lesion for gastric adenocarcinoma, and it is an H. pylori sort of initiated lesion, which we should all be familiar with. These are the mapping biopsies that you should be taking if you have a patient with gastric intestinal metaplasia. And this is recommended here. This is, these are supported by guidelines from the ESGE, the ASGE, as well as the British Society. You take 2 biopsies from the gastric antrum, and you can see from the lesser and greater curve, and the same thing from the body and the junction. So a total minimum of 5 biopsies should be taken for mapping for patients with gastric intestinal metaplasia. How good are imaged enhanced techniques for detection of gastric intestinal metaplasia and dysplasia? This is a systematic review and meta-analysis of 10 studies, close to 1,400 subjects, in which GIM was diagnosed in 35% of these patients. This is normal gastric mucosa without any infection or intestinal metaplasia. And then look at features that are suggestive of intestinal metaplasia. Light blue crest, which is shown here. A villus pattern within surrounding normal mucosa. And what they were able to show is that in this meta-analysis, that NBI and enhanced imaging increased the detection of GIM in an additional 32% of the subjects over and above white light endoscopy. But again, this was done in expert centers and in an enriched population. But the basic theme still remains. White light endoscopy is the baseline. Start using other techniques to help you get better in looking at these things. Longer exam time and gastric cancer detection. We're all aware of our study, which Neil Gupta did on Barrett's esophagus, but this is the same concept for upper endoscopy. This is a Korean study, and in Korea, gastric cancer and intestinal metaplasia is quite prevalent. And they decided to use a 7-minute cutoff time for an upper endoscopy. So very similar to 6 minutes or 8 minutes, which are proposed, during colonoscopy of withdrawal time. And they separated out endoscopists either less than 7 or greater than 7. And what they showed was that these so-called slow endoscopists, which I would say are those who are performing a quality endoscopy, had 3 times as many neoplastic lesions which were detected as compared to fast endoscopists. So if you think you're fast, you may not be doing a great job, and you may be missing lesions, at least in several studies which have come out. So the push is always for high quality colonoscopy, but I think the time is there for high quality upper endoscopy, and quality metrics are being developed around that. So I think it's an important concept to look at because it's important. I've shown you a number of imaged enhanced techniques. What does our society say? When should these techniques be ready for prime time? And these are the PIVI criteria, which Brian Finnerty and a number of ASG experts developed several years ago. And at least for Barrett's esophagus, what we said is advanced imaging technique should meet or exceed the following criteria. And we provide per patient sensitivity, negative predictive value, and a specificity. So again, the concept remains get better at the technique. And if you're able to achieve these criteria, you can start using that routinely in your practice. But again, the way you will do it is by attending meetings like this, looking at live endoscopy from Düsseldorf, and of course, then also reading about it and getting good in your practice to do that. Finally, it's difficult to talk about endoscopy these days without mentioning artificial intelligence, because it's at our doorstep. And, we've just written this review along with Cesare Hassan about why artificial intelligence for upper GI neoplasia. Well, remember, 35% of all GI cancers are upper GI cancers. 1.5 million cancer deaths worldwide are there. So it's an important cancer. Upper endoscopy is good, but again, has drawbacks. And missed gastric cancer has been reported about 10% of endoscopies. Miss rate, we know that if you repeat endoscopies and patients are referred to expert centers, you can miss neoplastic lesions in Barrett's esophagus. And there are several possible reasons. Maybe you're not washing well, you're doing incomplete exposure, visual failure by the endoscopist. And I think that's where artificial intelligence can help in alerting the endoscopist and then allowing us to detect and diagnose more. So there's several studies, but I'll tell you what's the goal of this. The goal of AI in upper GI lesions would be for recognition, characterizing them, telling you what areas within a big lesion are invasive cancer, for example, versus non-invasive cancer. What's the extent of the lesion? Because we struggle with doing an R0 resection. So these are all potential applications. Let me just show you one such study. This was done for esophageal squamous cell cancer, and this is the same concept. White light endoscopy followed by virtual chromoendoscopy. And then this bounding box appears, which shows you. And in this study, they compared the diagnostic performance of an AI system versus experts. And you can see that very high sensitivity and negative predictive value in this situation. This has been tested in Barrett's esophagus, in gastric cancer, intestinal metaplasia, with very promising results. I'll just summarize this by the systematic review and meta-analysis of 23 studies, accuracy of AI in upper GI neoplasia, close to 900,000 images. And you can see that the AUCs were extremely high for the detection of upper GI neoplasia. So the future appears bright in this situation. But, several biases, which again, I'll just list, that there's a selection bias of patients, operator bias using expert endoscopists, overfitting bias, and this is there for both the testing and the training set. So you have to be careful as you start reviewing all these studies, but I think this is the future of gastrointestinal endoscopy for this. So I'll end up with my final opinion, and it's not my opinion, it comes from this technology magazine, that the technology can be only as good or as bad as the user, which is all of us as endoscopists. So let's all do a better job at endoscopy. So again, Torsten and Klaus, thank you very much. And also to Horst for this wonderful symposium. Thank you.
Yeah. Thank you, Pratik, for your flexibility to give your lecture twice. We very much appreciate this. I thank both of you for your exciting lectures, and I would like to also ask both of you to join us for a little bit of discussion. We lost a little bit of time during fixing the problem, but maybe we have some time for some questions. So we have a couple of questions from the chat. So I will start maybe with the first one. So Pratik, you showed us very nicely how you can expose in the Barrett's patients the mucosal surface, very nice images, and maybe in these ideal situations, everybody is able or may be able to identify lesions, but it's very difficult to achieve these kind of positions of the endoscope to have a clear image. So what is your strategy to optimize imaging in difficult situations? Do you use caps, or how do you approach these kinds of esophagus?
Okay, thanks, Torsten. So, you're absolutely right. Is how should we do it? How can we get better? And, I'd say that we should try to strive for it for every endoscopy or upper endoscopy that we do. So there are many simple tricks. One of that you really mentioned, which is using a transparent cap at the tip of the endoscope. It should stick out only about 2 to 3 millimeters, not more. I'll use it not for all surveillance endoscopies, but specifically those patients who are either referred with a diagnosis of neoplasia or somebody being referred for endoscopic treatment. I'll definitely use that. So that's one start. A good, well-sedated patient so that you can spend your time doing the inspection. You start off with good cleaning. All of our endoscopes now come with the flushing pumps. So use the flushing pump generously. Keep the patient's head end raised up a little bit so that all the fluid goes into the stomach. You reduce the chance of aspiration for the patient. Use simethicone, use anything to reduce the bubbles. Then start your gradual inspection once you have a clean esophagus. And this is what I call as the split prep for the esophagus. We talk about the split prep for the colon, but we never talk about, what's the best split prep for the esophagus. And this is what it is. So do this, then start your gradual pullback and, try to inspect and spend time in the esophagus. A good rule of thumb is to spend about 1 minute per circumferential centimeter of Barrett's esophagus. So if you have somebody with C4, M7 Barrett's esophagus, you should be, spending at least about 5 minutes in doing all of this before going to your biopsies.
Wonderful. Thank you, Pratik. Uli, we have a question from the chat directed to you related to Z poem, and specifically when patients might be able to start an oral diet after the procedure. But tell us a little bit more about your setup in general for Z poem. Do you always get the surgeons at least notified, or is this now so safe that you're doing this on your own? Antibiotics, yes or no? Diet rules and regulations. Talk to us a little bit about those general issues.
Yes, Klaus, thank you for the question. I just do it without calling the surgeon, or I don't inform the surgeon for that. I do it under general anesthesia. And then after closing the entrance with clips, the patient goes to the ward again. The patient stays knee at mouth for 1 day. And at the next day, he's allowed to drink. He's allowed to take in fluid cost form. And then we do antibiotic prophylaxis for 1 day. My experience is that patients with Z-POM have minor inflammation in the laboratory values compared to the normal Senka diverticulotomy. But it's only my personal experience.
We have one more question from the chat, also referring to your very exciting therapeutic lecture. So you have shown this nice video on treating of a Zenker's diverticulum with the scissor-type knife, the clutch cutter. So the result was impressive. So the question is, when do the patients start oral feeding after that, after this procedure? When do you start?
I think we all Senka procedures are kept kneel at mouth with 1 day and then only fluid, and we start after 3 days with eating. But probably this differs between the different centers. I don't know if everyone does it the same way.
Wonderful. And I would like to encourage the audience, keep sending us your questions online. We're going to try to get as many of them as possible to the moderators. Pratik, for you, in this month's Journal of Gastrointestinal Endoscopy, I think you and your collaborators provided the results of a study talking about the issue of, we have all these fantastic diagnostic modalities as you've just laid out for us. At the same time, we're not maybe always optimizing our exams. You've alluded to it in your talk. you presented this Acquire study looking at education for our colleagues to essentially for all of us to help do our jobs better. What are the main gaps, would you say, where if I go back to my unit tomorrow and I want to do a better job, what is the one or two things that I can do to get better?
Yeah, thanks, Klaus. I mean, and for the audience, I mean, Klaus is referring to the Acquire study, which was a randomized control trial. Again, a very simple concept. We took 8 sites, endoscopy sites, community sites in practice, and we randomized 4 of them to, Barrett's education, and 4 continued their standard of care. And the Barrett's education that we provided was quite simple. We visited each site. We went over, upper endoscopy landmarks with them. Where is the gastroesophageal junction? How do you define the gastroesophageal junction? Where is the diaphragmatic hiatus? How to differentiate a hiatal hernia from a columnar-lined esophagus? How to inspect, how to take the Seattle biopsy protocol, 4-quadrant biopsies every 2 centimeters. We gave them a couple of posters to put them in their endoscopy rooms. And then we gave them like some monthly feedback via email saying that, hey, a reminder to use all of this. And we followed them for up to 12 months. And at least in up to 12 months, the sites that were randomized to the simple education, that's what I'd call it, did significantly better in terms of using the PROG classification, in terms of using, following the guidelines for taking the biopsies, etc. So Klaus's point is well taken. I mean, we sometimes, spend too much time on new and better toys, but we forget sort of like the basics. So these are some of the basics, is that, just pay attention to your landmarks, do a good job in inspecting, take your time in cleaning. So, my dictum is that, look more, biopsy less. So always try to be more on the lookout, try to look for lesions, and try to take fewer random biopsies, take more targeted biopsies. And the only way you'll take target biopsies is if you find something abnormal.
Okay, Pratik, thank you very much. I think, unfortunately, due to the time, we have to continue in our program. I would like to thank both of you for your excellent contributions and the active discussion, and also for fixing these technical problems. So thank you very much to both of you. And I would now lead over to the second part of the Satellite Symposium that is now dedicated to the lower GI tract. And it's my great pleasure to welcome personally here in Düsseldorf Professor Alessandro Repici. So he for sure needs no further introduction, as is probably the busiest endoscopist in the world with the Endoscopy on Air platform, worldwide active. He's director of the digestive endoscopy unit at the Humanitas Research Hospital in Milan, Italy. And we are very much looking forward to your lecture on artificial intelligence and its impact on screening colonoscopy.
So thanks to the chairman. Thanks, guys, for the invitation. And it's a great pleasure being here. And I love to be in Düsseldorf, even though we are virtual, but it's a great atmosphere. These are my disclosures. That some of them may be relevant for the topic of my talk. So I'm going to talk about advanced imaging and artificial intelligence. And probably what I will briefly touch is why we need this, what we need, and how we can incorporate in our practice. So let's start from why. The forecast for the next 10 years is telling us that probably colorectal cancer is going to grow, despite the many countries have already adopted a screening program for colorectal cancer. And together with pancreatic cancer, we will witnessing a rise in the numbers. So we need to make better work in prevention of colorectal cancer, because colorectal cancer is a preventable one. Also, according to this statement of the UEG of our European Society society, in Europe, there is one death from colorectal cancer every 3 minutes. So this means that over the time of my lecture, number of patients will be dying because of a preventable cancer, which is colorectal cancer. And again, another major issue with the colorectal cancer that we are seeing more and more increased diagnosis of cancer, especially in the rectum of young adults. This has been reported in many papers. Now we know this is associated with the metabolic disease, with obesity, with bad behaviors in terms of diet. Again, we need to prevent also in these guys. And we know from this nice statement from this couple of experts in colonoscopy that colonoscopy is the medical procedure with the most profound and lasting impact on patients' life. So if you look to this forecast, in the next 10 years, we are progressing to over 100 million procedures worldwide. And the progression will be associated to a significant increase in the number of colonoscopies. So there is a huge impact in terms of money, financial resources, efforts, clinicians, nurses. There is big numbers of persons involved in doing colonoscopy. All of this cannot be jeopardized by the risk of having an outcome which is not always very good or reported with a very high ADR. We know that in colonoscopy, the major problem that we're seeing right now that's been reported in so many papers is ADR variability. And ADR variability just translates in adenoma miss rate. There are different papers showing that there is a huge variability either in screening program, outside screening program. These are numbers from US population reported in Clinical Gastro a couple of years ago. But we know that statistically speaking, on average, every time we increase 1% of adenoma detection rate, there is a 3% decrease in the risk of colorectal cancer. So this is important for us. We need to go to all technologies available to report as much as possible to improve our adenoma detection rate. Based on our one of the latest meta-analysis that we have published in the Lancet Gastro, it's absolutely clear that when you use optimal imaging modalities and you add on top artificial intelligence, this is going to be the best method to improve ADR and to keep ADR very high over time. So what? So quality colonoscopy, this is the answer to answer to this huge demand of protection of our patients from colorectal cancer. The answer is quality colonoscopy, which technologically translates in advanced imaging plus artificial intelligence. For doing quality colonoscopy, there are human factors and technical factors and technology factors. All of them, they do produce excellent results and allows us to see also these flat lesions into the right colon that have been reported as one of the major problems with the interval cancer in many papers. Advanced imaging is a long story from high definition to virtual reality. There is a lot of things altogether, and they are moving so fast that it's very difficult to follow all of them in the proper time. Advanced imaging means that when you do screening colonoscopy, you should be able to provide the patients this level of technology that allows you either to identify tiny adenoma, depressed adenoma like the one on the left screen, or hyperplastic, and discriminate hyperplastic from adenoma. Of course, we are getting a lot of advantages from development on AI and object detection, and AI is probably changing the way we are doing colonoscopy. You see how many different applications of AI have been reported in the field of colonoscopy. Why we need this? Because we need to go beyond human level performances. When we We use AI in colonoscopy. There is no risk of fatigue. It's always working, always supporting the diagnosis of polyps, and adenoma is operator independent. Of course, when there is a physician doing the procedure, everything can turn in the wrong way, and we may have fatigue, we may be busy or not paying the right attention to what we're doing. So this is why we need to go over our performances. In a 15 minutes endoscopic procedure, there are 30 high definition frames per second. So many thousands of images that it's very easy. We can miss some of them, and so we can miss a relevant lesion as well. How we do that? How we can overcome this problem? There is a high universe in endoscopy, and a lot of systems are available in Europe. Fujifilm was the first to be approved for KD detection and KDX characterization. And how to do this is incorporation in your practice. It's just one more box in the tower of endoscopy. And of course, when you use a system that allows you to incorporate in the same time detection and characterization, that will be very helpful. And also for your team, for the nurses, for the physician, adoption of use will be very quick. KEDAI is the Fujifilm system and algorithm for artificial intelligence that allows you to improve real-time detection and tissue characterization, just diagnose between hyperplastic and adenomatous. This is a simple video that shows that there was a tiny polyp about 5 to 10 millimeter polypoid lesion I was going to miss, but even though you are not paying the right attention, there is a sound alerting you, there is a visual box just reminding that you have to go in that direction. And also it's important, CADX, so histology prediction. This is the latest statement from European Society of Gastrointestinal Endoscopy, telling us that we need to improve in resect and discard strategy. We know that adopting resect and discard strategy and following the PV threshold that have been set by the American Society of Gastrointestinal Endoscopy, we can save a lot of money. There are papers saying that probably adopting globally resect and discard strategy, the save in terms of money can be close to 1 billion. So, of course, for doing that, you need a very good system. And this is a video showing a very nice case with a very challenging lesion. We know that serrated lesion can have a dysplastic component. You see, the machine was able, you see in the right part, it's a mix of green and yellow. Green is hyperplastic, yellow is neoplastic. So the machine was able, the algorithm was able to catch that the lesion has a dual component, hyperplastic, like the serrated one, neoplastic, the dysplastic one. And this is very helpful, especially for those who do not have great familiarity with this kind of lesions. So we are working on that. We are doing a lot of studies, and we are now completing what we call it the combo study. We submitted the data to DDW. Hopefully we will be able to present in person this year if the paper gets accepted. We did a prospective evaluation of 2 different systems of AI for colonoscopy, and we looked at small and diminutive polyps into the rectosigmoid. We enrolled over 380 polyps, and we looked at the PV criteria, and when we looked at the diagnostic sensitivity, specificity, negative predictive value of the 2 X systems, either the KDI or GI Genius, they were very equivalent and much better than the human eyes. So we are confident that improving more and more the adoption of these systems in the clinical practice, we can fully adopt the resect and discard strategy. Also, when I do presentation about AI, there are a lot of questions about false positive, telling me how noise can be, how much time you are increasing your withdrawal time. Is this going to be a relevant issue? So always the answer is, please have a look. So video is very clear, you know, there are a lot of seeds into this column. This is not disturbing a lot, it's not altering my vision, it's not creating any problem. Also, we did a nice study on that. We compared the number of false positive, false activation, again between two different systems, the KDI, the GI Genius. We call this the noise study. And also we looked to the impact on withdrawal time, and the paper is already online on gastrointestinal endoscopy. It's been approved just a few weeks ago. And according to our results, GI Genius and KDI, they have a very minimal impact in terms of false positive. They do not impact withdrawal time. They do system performed equally. So we have very robust evidence that we can uptake this in our practice. Of course, this is just the beginning of a big journey, and the big journey is bringing us a lot of innovation, and the next will be sizing and quality control and amount of mucosal exposure and evaluation of the bowel prep. So please get ready to improve the technology that you are going to use, and also to change your mindset. We need to be much more open and take this as an innovation that is going to improve our quality measure, our adenoma detection rate, and save more life from colorectal cancer. Of course, artificial intelligence is not the boss. Please remind you remain the boss of the colonoscopy and get full control of the decision you're doing during the procedures. Thank you so much for your kind attention.
Thank you very much, Ali. Please accept our virtual hand clapping for yet another fantastic lecture. In a moment, I would like to introduce our last speaker, but before I do, I want to once again thank our sponsor, Fujifilm, for making this symposium possible. The last 2 years have really been extremely challenging for all of us and our patients, and the dedication of companies like Fujifilm to continue to support events like the Düsseldorf course is extremely valuable to all of us. We have hundreds of attendees on the line with us for this symposium, and we are all, I know, very grateful to Fujifilm for their continued support. So thank you. Secondly, and not the least, to the attendees, please send us your questions for Dr. Rapici and soon for Professor Kieslich, and we will pass them on in our final Q&A. And with that, it really is a great pleasure. I see him on the screen in front of me already, which is why I'm smiling, to introduce to all of you Professor Ralf Kieslich, who of course doesn't need an introduction. Ralf and I have known each other even back when we both had a different hairdo. We were colleagues together in Mainz, and it's been wonderful to see his rising through the ranks. Professor Kieslich held several leadership positions, most recently in Wiesbaden, where he led the gastroenterology department. He now has taken another very important step and assumed a management leadership role in Helios Kliniken, one of the large health systems here in Germany. We desperately need physicians to be part of the top management ranks of our health systems. And so I was very glad to see Ralf advance to that position. Ralf, welcome, and we're looking forward to your talk on therapy in lower GI. Take it away.
Klaus, it's always a pleasure seeing you, ladies and gentlemen. Klaus is a true leader, and I always follow him, and now I have also the same haircut as he mentioned. It's a wonderful symposium. I'm very unhappy not to be there in Düsseldorf, but due to the management position, which has also to do with the management of Omicron and the Corona wave, I have to be here in Wiesbaden, but it's great to be with you, at least online. So you will hear now the recorded video, and then I'm happy to answer your questions.
Thank you for the kind invitation. It's my pleasure to speak with you about artificial intelligence and how we are coming from screening to intervention. There might be a new paradigm in endoscopy, which means we're coming from screening, we are going to intervention, but what is the value of artificial intelligence? And you have already heard from Alessandro Repici how artificial intelligence will impact screening in colonoscopy. There might be even a step further if you use the GI technology. What is the GI technology? It is a balloon technique where a balloon is embedded on the distal tip of an otherwise normal endoscope. You can use your endoscope, and then this balloon becomes part of your endoscope if you send this in, and then the balloon is put onto the distal end. You insufflate the balloon whenever you need it, mainly it's during the withdrawal, and then the folds are flattened, your optic is centered, and the air in front of the balloon is caught, so you have a better overview of the mucosal surface. You see here the technique of the GI endoscopic system, and here you see the flattening of the balloon, of the folds, and then the polyp behind the folds can be better visualized. So what is the value of GI? And we have performed a randomized controlled study where we compared the GI colonoscopic system versus standard colonoscopy. And you see here in the standard colonoscopy arm, were almost 400 patients, and in the GI arm, 407. And you see there's a significant increase in the adenoma detection rate coming from 37.5% towards 48%. And furthermore, there were significant more flat adenomas and more advanced adenomas who could be identified by using the GI endoscope. The next question is, what is better? Is it GI, the balloon, or is it the endocuff system? And we also performed a randomized controlled trial where 2 American sites were implemented, Z-Cross and Douglas Rex and the Wiesbaden. And we performed in a 1-to-1 ratio, a randomized trial where we compared the efficiency of endocuff colonoscopy versus GI colonoscopy. The results of this trial were presented at the annual scientific meeting of the American College of Gastroenterology, which was held last year in Las Vegas. You see here the difference. With the endocuff, you have the plastic spikes and you have to observe one fold after the other. Whereas with the balloon system, you have more centered view. The folds are, in my view, more flattened, and you have a better overview over the whole segment of the colon, for example, here in the sigmoid. And then after a while, you will identify some polyps, and we counted the number of polyps, and we also noted the morphology of the polyps. And then it was interesting to see that the adenoma detection rate could be significantly increased from 54.3% towards 63.9%. And moreover, there were significant more flat adenomas and more advanced adenomas which could be identified. What is the workflow of cat-eye and GI? And it's not only about detection. Here you see a polyp which is detected. It's also about characterization, because with the BLI technology of cat-eye, which is the Fuji system, you also can not only have detection, you also get the characterization mode, and therefore you find a diagnosis of your colonic polyp. And here, this is an hyperplastic polyp. And then after a second, this polyp was removed, because in our study, we have to identify whether our prediction based on cat-eye was true or not. The system also allows kind of a differential diagnosis. And here you have a patient with a lot of flat lesions. And here, for example, you see a serrated lesion. And by using the characterization mode, then there was a neoplastic serrated lesion indicated and endoscopic intervention was performed, whereas here is an area from a former resection just below this neoplastic lesion. You see it right here. And if you make here a tissue diagnosis, this was a hyperplastic lesion. Here you see it's not switched on, the cat-eye system, but now I switch it on. And immediately you see this red spot, which is very shallow and small. But if you go closer to that area, you will see that this is a depressed area with some irregularities. And by using the BLI mode and cat-eye in combination, depressed early cancer could be identified. However, there are also diagnostic challenges with the system. And sometimes you have the problem that the delineation of the lesion is not perfect, but you still see the squares indicating that there's a lesion which have to be identified. You also see sometimes here a lesion which is raised on that area, but on the left-hand side, there's still some area which belongs to that flat lesion. And on the other hand, you see that artificial intelligence, like the cat-eye, really helps you to identify sometimes lesions which are really hard to see. This is almost missed polyp. You work very controlled with the balloon by using the GI balloon, which is not seen in the optic. You very rarely, like you have seen, you have this slippery phenomenon where you just go over an area, but in a millisecond, the computer has identified that between these two folds, a polyp was seen, and you hardly will miss it because you were notified by the cat-eye system. And also, we sometimes do make mistakes if we look in one area and we think this is the most important area, but we also have to see and identify some other areas. Here's a polyp, looks pretty benign, and it was in fact a lipoma. Due to study reasons, I made a characterization with the cat-eye system showing that this is a benign lesion. I still look on that part, but here on the right-hand side, there's another small adenoma, but that might be missed because we were so much focused on the bigger lesion, but here a small adenoma could be identified. We did some cat-eye evaluation, and you see that the adenoma detection rate went up from 45% to 63% by combining cat-eye with GI, because the false positive rates of identifying polyps was reduced because GI is kind of more controlled, and because you provide more mucosal surface to be seen also for the computer algorithm, more adenomas could be identified. There is still an issue in the detection if you have serrated lesions. So sometimes the computer says benign lesion, but in fact it is an adenoma or dysplasia inside. And also inflammatory changes are sometimes mislead the computer to make the diagnosis neoplasia. So sensitivity and specificity combined lead to an accuracy about 87.6% in the 307 lesions we have evaluated. But now we're coming to the endoscopic interventions, and that is the new paradigm what we can use, because the GI system allows you to anchor your endoscope in front of a lesion. And here we have GI, which anchors in front of the lesion. This is a hyperplastic lesion, but in fact it's a serrated adenoma, which is clearly being identified. And now we have to remove this lesion. And what normally can happen that you sometimes lose your position, or it's very difficult to have the position right in front of the balloon. And by doing the withdrawal with the GI system, you have a more softer pressure of the balloon, which is automatically adjusted. Here now you have the anchoring mechanism, so you can place your distal tip right in front of the polyp. You can't see the balloon because it's behind the optic, but allows you to work very precisely here to do the removal of the polyp. Here I attempted to do an en bloc resection, but I still have some parts here, and I immediately can work further to resect this part here and guide my snare. And also, if I do the resection and look further on that lesion, we still see a little part here, and it gives you the possibility to make a very controlled resection, because the balloon is an additionally a helper to get a very stable position in front of a polyp. So this was a piecemeal resection. If we talk about en bloc resection, then you might see here this combination of cat eye and GI colonoscopy, which coming with this Fujifilm colonoscope with highest resolution. And you see here again a flat lesion, serrated lesion, and here now the injection. And normally, by performing the injection, you are sometimes pushed back, but because the balloon is anchored in front of the lesion, you can still hold your position in front of the polyp. And now if you use your 10 millimeter snare, what is my favorite snare, even in that big lesion, and you can suck a little bit and you can here very precisely perform en bloc resection with some free margin and do the resection in one piece. So we evaluated our outcome parameters in 1,362 patients with standard colonoscopy and over 1,400 patients with GI. This was presented at DDW 2020. And you see here that the intervention time for polyps between 5 to 20 millimeters was only 4.5 minutes by using the GI system and 7.2 minutes with the standard colonoscopy. And moreover, for the bigger polyps larger than 20 millimeters, we came down from 10.2 minutes up to 7.2 minutes, which was statistically significant. So to conclude, ladies and gentlemen, I think that GI allows to inspect more mucosal surface during withdrawal. GI is more effective compared to endocuff in terms of adenoma detection rate. And I think GI can be ideally combined with cat eye. It reduces the false positive results, and it does further increase the adenoma detection rate. And then as a second step, the GI helps you to anchor with a balloon, the insufflated balloon, in front of the polyps, and then reduce that the time for polypectomy due to that anchoring possibility. Thank you very much for your kind attention.
Yeah, thank you. Thank you so much to both of you for these exciting lectures. So I'm really flashed to see all these impressive images and the data behind. I would like to invite both of you to join our discussion, and I'm very happy that Professor Rapiti also joined us in this panel here on site, and Professor Kieslich will join from Wiesbaden. Yeah, we have a couple of questions from the chat, and I'm going to start now with the first question, and this may refer to both of you. So we have nicely seen that AI technology is able to increase the adenoma detection rate, and also that the additional use of exposure devices may add to this effect, and that also the balloon technique may be also superior to other exposure devices. So in your eyes, and this is a question from the chat, does the adenoma miss rate, is this more related to missing lesions that are not seen on mucosa that is not exposed, or is it a question of misinterpreting lesions that can be seen and are not or not supposed to be neoplastic lesions? What is your opinion?
Raf, you go first.
Yeah, I think it's a combined effect. As we know that tandem colonoscopy has shown that 26% of adenomas are missed. So any exposure device which helps that you can see behind folds will reduce the adenoma miss rate. On the other hand, we are not always 100% concentrated, so you also miss lesions which are on the screen. And I think the combination to see or to expose more mucosal surface and add artificial intelligence will really help to improve the quality in colonoscopy, because the adenoma detection rate will significantly increase.
I cannot agree more. Thanks, Ralph. It's a great pleasure to virtually meet you, and so long we don't see in person. And I cannot agree more. And I think more we can do in terms of technology adoption, more we can improve ADR. So this is going to be very nice. So if we can expose more mucosa will come to our eyes, more mucosa will be analyzed by AI. So the combination of the two should produce even better effect using just one of them.
Wonderful. We have lots and lots of questions coming in. I'll try to keep it short, and with short answers, we'll try to get through a few of them. Ralph, about GI, can you talk to us a little bit about potential downsides? There's a question from an audience member. Is there a risk in, for example, severe diverticulosis? And then I might add, tell us a little bit about the reprocessing of the endoscopes then. Is there a potential downside in using the technology?
So reprocessing was controlled and is possible with the endoscope and with all machines. And we were careful at the beginning because we thought diverticular might be a risk, but there is no risk. There's a very thin balloon, and the thin balloon is also automatically controlled. If the pressure is getting too high, the pressure will decrease automatically. So there were no side effects or adverse events by patients with diverticular.
And we have more questions coming in, and one may refer to a video that has been shown. In terms of the development of AI, will there be a solution to differentiate between hyperplastic lesions and serrated lesions? We have seen that the lesion we have seen in the video case was in fact a serrated lesion, and the system said it was a hyperplastic.
Yes, that's true. So that was an impact we had. That's why also the accuracy rate was about 90%. Alessandro might add, because he has also analyzed the cat-eye system, but that might be a problem which is really difficult to overcome, because the opening of the glands of a serrated lesion, non-dysplastic, is almost identically. It's only a little bit bigger than a hyperplastic lesion. So it's very difficult for the computer to maybe find the right diagnosis. However, on the right side of the colon, if we have identified a lesion, we anyhow have to remove it, because there's such a high probability that this will be a serrated adenoma on the right side of the colon.
Very good. More questions coming in about AI, maybe Ali, distinguishing between polyps and invasive cancer. How good are we at doing this without help, and how much can AI improve what we can do distinguishing malignant and benign polyps?
Okay, thanks. This is a great question. So we're doing a lot of improvements, because adoption of new technologies like BLI or Zoom is allowing us to make a very detailed analysis of vascular pattern and a P pattern. So already with advanced imaging, we are very good in differentiating also in small lesions those polyps which may have invasion of submucosa or advanced histology. With regards to AI, I think this is coming. So I think the next couple of things that are being developed by AI producers are sizing of the polyps, mucosal exposure, characterization of serrated lesion, but also characterization of neoplastic invasive lesions. Especially for the last 2 points, serrated style lesions and advanced neoplastic lesions, probably in the future we need to work more and more with the pathologists, because we have to train the algorithm about using endoscopy pictures and pathology slides. And I think that the combination will be great. It will upgrade the system at the level that we will be very close to the pathologists in make immediate diagnosis to provide information to the patients at the end of the procedure.
Yeah, wonderful. So unfortunately, although we have still a lot of questions coming in, we have to come to an end now. And so I thank all 4 speakers for their outstanding and exciting contributions and the lectures. And I think we had very active discussions and active participation by all participants sending in their questions. So I thank you all participants for joining, and also want to thank Fujifilm again for hosting this symposium and for your great support during these difficult times. And finally, I would remind you to stay tuned and stay online for the coming 2 exciting satellite symposia today, and hopefully tomorrow for the opening of the main congress. Almost 8 hours of live endoscopy cases will be broadcasted from the EVK, and you can admire the endoscopy skills of some of the experts you have listen to right now. So thank you for joining today. Thank you to all speakers, and thank you for joining. Stay healthy and stay tuned. Goodbye.